Welcome back, future nurses. We are delivering daily 3 to 4 practice tests. Today, we will be focusing on the nursing care of clients with degenerative disorders, a topic that challenges both our knowledge and compassion. Conditions such as Parkinson's disease, multiple sclerosis, and amyotrophic lateral sclerosis are not only progressive but also deeply impact mobility, independence, and quality of life. As nurses, our role is to support these clients through every stage, promoting safety, maintaining function for as long as possible, and preserving dignity. In this session, we will cover key pathophysiology, priority nursing diagnoses, interventions, and high-yield NCLEX strategies that will equip you to provide excellent care in both acute and long-term settings. Get ready to strengthen your critical thinking and walk away with practical tools you can apply directly in your exam and clinical practice. Hold on. There is something exciting for you. All I want to give you, something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX Prep, interactive live classes, and easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lectures. This isn't just another review. It's everything you need in one place. Scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. To continue our journey into neurologic nursing care, let us look at the case of an older adult who has been newly diagnosed with Parkinson's disease and admitted to a long-term care facility for supportive management. This client is showing features such as bradykinesia, mild rigidity, a soft monotone voice, and intermittent tremors. Before creating an individualized plan of care, the nurse must first decide which assessment finding is the most essential to evaluate. Here are the options. The client's ability to perform activities of daily living. The client's preferences for and dislikes of various foods. The family member's views about nursing home placement. The client's feelings about giving up independent living. The correct answer is option 1. The client's ability to perform activities of daily living. Now let us carefully examine why this is correct. Parkinson's disease is a progressive neurodegenerative condition caused by depletion of dopamine in the basal ganglia, which disrupts smooth and coordinated movement. As dopamine falls, the client develops tremors, rigidity, postural instability, and slowed movements, all of which directly affect the capacity to carry out essential daily tasks like feeding, bathing, dressing, and toileting. A baseline assessment of activities of daily living provides the foundation of the entire nursing plan. It also guides referrals to physical therapy for mobility, occupational therapy for adaptive equipment, and speech therapy for swallowing or voice difficulties. If this assessment is missed, the nurse risks overlooking critical issues like fall prevention, aspiration, and progressive dependence. Based on Maslow's hierarchy, physiologic functioning and safety always come before psychosocial concerns, making ADLS the top priority. Turning to option 2, which is about food preferences, this is certainly valuable for quality of life, but it does not override the need to first identify functional limitations. Dysphagia is common in Parkinson's disease due to oropharyngeal weakness, and while food choice matters, it cannot be safely implemented until the nurse knows whether the client can chew or swallow effectively. Looking at option 3, the family's views about nursing home placement provide insight into social support and adjustment. However, care must remain client-centered. The nurse's immediate role is to assess the client's actual physiologic and functional abilities before exploring family perspectives. Finally, option 4 highlights the client's emotions about losing independence. While this is important for long-term adjustment, since depression and anxiety are common in Parkinson's, it comes after ensuring safety and mobility. Emotional adaptation strategies such as counseling or support groups are most effective when built on a foundation of functional independence and safety. From a clinical integration standpoint, remember that Parkinson's disease stems from degeneration of dopaminergic neurons in the substantia nigra, disturbing the balance between dopamine and acetylcholine, Key nursing priorities include preserving mobility, preventing falls, maintaining swallowing safety, and supporting medication adherence, especially with agents like levodopa-carbidopa. Interdisciplinary collaboration with physical, occupational, and speech therapists maximizes independence. Over time, vigilance is required for complications like aspiration pneumonia, contractures, pressure injuries, and caregiver strain. Stand-Coast-Pearl. In chronic neurologic conditions such as Parkinson's disease, always assess functional independence first. Activities of daily living set the stage for every other aspect of care, from nutrition and safety to psychosocial support and family involvement. Let us now move into another essential high-yield NCLEX teaching script. Imagine you are in a classroom where a nurse educator is preparing newly licensed nurses to recognize Parkinson's disease early. The educator poses the question, which clinical manifestation is most commonly identified as the initial presenting sign of Parkinson's disease, and is often first noticed by the client before others? Here are the options for consideration. First, muscle rigidity. Second, muscle tremors. Third, muscle weakness. And fourth, muscle deterioration. The correct answer is option 2, muscle tremors. When we carefully analyze this, the reasoning becomes clear. The very first hallmark sign of Parkinson's disease is usually a resting tremor, often described as a pill-rolling movement between the thumb and fingers. This tremor typically begins on one side of the body and may appear so subtle that clients themselves are the first to notice it. From a pathophysiologic perspective, Parkinson's results from progressive degeneration of dopaminergic neurons in the substantia nigra of the basal ganglia, producing an imbalance between dopamine, which is inhibitory, and acetylcholine, which is excitatory. The imbalance manifests first as abnormal rhythmic movements, tremors, before other features set in. Detecting tremors early is vital because it opens the window for interventions such as levodopa-carbidopa therapy and non-pharmacologic support, like physical or occupational therapy to preserve independence and safety. Turning to the other choices, muscle rigidity, while it is indeed a classic feature, especially the cogwheel rigidity pattern, usually follows tremors rather than appearing first. As for muscle weakness, Parkinson's disease does not begin with true muscular weakness. Instead, clients experience bradykinesia, or slowness of movement, which can be mistaken for weakness but is neurologic rather than muscular in origin. Muscle deterioration, on the other hand, is a much later finding that develops secondarily due to immobility, disuse, and nutritional decline. It is not an early diagnostic clue. From a clinical integration standpoint, nurses must focus on assessing how tremors affect fine motor tasks, such as dressing, eating, or writing. This not only highlights the functional impact, but also directs safety interventions, since tremors can contribute to falls or self-care difficulties. Moreover, recognizing tremors early allows timely collaboration with the interprofessional team, including physical therapy, occupational therapy, and speech therapy, to maintain independence and prevent complications. And here is the Stand-Coast-Pearl. Tremors tip you off first. In Parkinson's, tremors at rest are the earliest clue, rigidity and bradykinesia follow, while weakness and muscle wasting appear only in later stages. As we progress to the next question, let us focus on a common challenge faced by clients with Parkinson's disease. A client diagnosed with Parkinson's disease is prescribed levodopa-carbidopa, commonly known as Sinemet, 3 times daily. During the morning medication round, the nurse notices that the client is struggling significantly to swallow the capsule form of the medication. The question is, considering both safety and therapeutic effectiveness, which nursing action should the nurse take? The options provided are as follows. The first option suggests soaking the capsule in water until it softens before administration. The second option recommends instructing the client to chew the capsule thoroughly before swallowing. The third option proposes opening the capsule and placing the contents directly into the client's mouth. The fourth and final option advises offering the client small sips of water to moisten the oral cavity before swallowing the capsule. The correct answer here is option 4, offering the client small sips of water to moisten the oral cavity before swallowing the capsule. This is the safest and most effective intervention. Clients with Parkinson's disease frequently experience dysphagia due to bradykinesia and impaired oropharyngeal muscle control. By moistening the mucous membranes, the capsule passes more smoothly, lowering the risk of aspiration while maintaining the medication structure and intended therapeutic release. This not only protects the client's airway, but also ensures that the drug continues to act effectively. On the other hand, soaking the capsule in water, as suggested in option 1, is incorrect because capsules are designed to dissolve at a controlled rate within the gastrointestinal tract. Altering their structure may change absorption patterns, reduce efficacy, and increase choking risk if the softened capsule breaks apart. Moving to option 2, instructing the client to chew the capsule is also unsafe. Capsules are not designed for mastication, and chewing can cause a bitter taste, oral irritation, and a dangerous dose dump, which might lead to fluctuating dopamine levels, worsening dyskinesia, or side effects such as orthostatic hypotension. Now looking at option 3, opening the capsule and placing the contents directly into the client's mouth is inappropriate because the powder has a bitter taste, irritates the mucosa, and disrupts the controlled absorption process necessary for effective management of Parkinson's symptoms. Clinically, it is important to remember that dysphagia in Parkinson's patients heightens the risk of aspiration and pneumonia, which can be life-threatening. Nurses should therefore prioritize safe swallowing techniques, collaborate with speech and swallow specialists when necessary, and advocate for alternate drug formulations if swallowing difficulties persist. For instance, orally disintegrating tablets or liquid suspensions of levodopa, carbidopa may be prescribed as long-term solutions. Here is your Stand Coast Pearl. In Parkinson's disease, safe medication delivery is just as important as the drug itself. Always protect the airway, preserve the integrity of the capsule, and remember that early referral for swallow assessments or alternate drug forms ensures both safety and sustained therapeutic benefit. Let us now move into another carefully designed NCLEX practice scenario. A nurse is developing a teaching plan for a client who has just been diagnosed with Parkinson's disease. Considering the clinical manifestations of this progressive neurodegenerative disorder and the risks associated with its progression, which instruction should the nurse identify as the highest priority? Here are the possible options. The first option emphasizes daily steps to enhance the client's immune system. The second option highlights the importance of maintaining a balanced and nutritious diet. The third option instructs the client and family about the need to remove environmental safety hazards. The fourth option encourages the client to maintain regular social interactions and support networks. The correct answer is option 3. Instruct the client and family about the need to remove environmental safety hazards. Now, let us explore why this is correct. The most important priority in Parkinson's disease is ensuring safety. This condition results from degeneration of the basal ganglia and dopamine depletion, leading to classic motor symptoms such as bradykinesia, rigidity, postural instability, and a propulsive shuffling gait. These impairments significantly increase the risk of falls, which can cause fractures, head trauma, and rapid loss of independence. By teaching the client and family to eliminate hazards such as loose rugs, clutter, unstable furniture, and poor lighting, the nurse directly addresses immediate safety risks. This aligns with Maslow's hierarchy of needs, where physiologic stability and safety come before psychosocial or long-term wellness interventions. And it matches NCLEX frameworks that emphasize risk reduction as the first nursing priority. Shifting to the first option, which suggests enhancing the immune system, this is incorrect. While good immune health contributes to overall wellness, Parkinson's disease itself does not primarily weaken immunity. Promoting rest, hygiene, and vaccinations may help reduce infections, but it does not directly address the most urgent safety risk posed by impaired mobility. Looking at the second option, teaching about a balanced diet is also important, but not the immediate priority. Nutrition is indeed critical in Parkinson's disease because dysphagia, constipation, and weight loss are common. A high-fiber diet with adequate fluids helps prevent constipation, and timing protein intake can optimize levodopa absorption. Still, these are long-term management strategies, not the most urgent teaching point when compared to fall prevention. Considering the fourth option, encouraging social interactions, this too has value but remains secondary. Socialization helps prevent depression, isolation, and cognitive decline, while also strengthening adherence to therapy. Yet psychosocial needs always rank after physical safety in nursing priorities, making this option incorrect for the immediate teaching focus. From a clinical integration perspective, the nurse should assess gait patterns, the use of assistive devices, and fall history, collaborating with physical therapy to teach safe ambulation, recommending non-slip shoes, bright lighting, grab bars, and adaptive devices such as elevated toilet seats are crucial safety-focused interventions. And here's the stand-coast pearl. Parkinson's clients fall forward, safety comes first. Remove hazards early before focusing on diet, immunity, or social support. Let us continue building your NCLEX script with this thoughtful scenario. A nurse is developing long-term goals of care for a client who has just been diagnosed with Parkinson's disease. Because this condition is chronic and progressive, the nurse must determine which goal is the most realistic to prioritize in the plan of care. Here are the available options. The first option is to reverse the symptoms and cure the disease. The second option is to stop the progression of the disease process. The third option is to maintain optimal muscle and motor function. The fourth option is to prepare for a progressive terminal disease. The correct answer is option 3, to maintain optimal muscle and motor function. This is the most realistic goal because Parkinson's disease is caused by the degeneration of dopaminergic neurons in the substantia nigra of the basal ganglia, which leads to dopamine deficiency. This imbalance between dopamine and acetylcholine is what causes hallmark symptoms such as bradykinesia, rigidity, tremor at rest, and postural instability. Since the disease is both chronic and progressive, medications such as levodopa, carbidopa, dopamine agonists, and MAO-B inhibitors can significantly reduce symptoms, but they do not cure or stop progression. The nurse's primary role is to help preserve mobility and independence by promoting exercise, physical therapy, occupational therapy, and safety interventions. This helps delay complications such as contractures, immobility, and falls, making functional optimization the best achievable goal. Now, let us explore why the other options are incorrect. Option 1, which states to reverse the symptoms and cure the disease, is not realistic because no current treatment can cure Parkinson's. While medications and surgical procedures like deep brain stimulation improve symptoms, they do not reverse neuronal loss or restore dopamine. Option 2, to stop the progression of the disease process, is also not accurate. As neurodegeneration continues despite pharmacologic management, nurses must set realistic expectations and educate families that Parkinson's is progressive but manageable for many years. Option 4, to prepare for a progressive terminal disease, may sound logical, but is misleading because Parkinson's disease is not immediately terminal. With proper care, clients often live for decades. Terminal complications such as aspiration pneumonia or severe immobility occur only in late stages. So this is not the priority goal at the time of diagnosis. From a nursing care perspective, the focus should be on exercise and stretching to preserve mobility, teaching about the timing of medications to reduce on-off fluctuations, and implementing fall prevention strategies due to shuffling gait and postural instability. Interprofessional collaboration with physical, occupational, and speech therapists also enhances independence and swallowing safety. Here is your stand-coast pearl. In Parkinson's disease, we cannot cure or stop progression, but we can preserve function, independence, and safety for as long as possible. The nurse's role is to set realistic goals, reduce fall risk, and maximize quality of life. To move forward in our discussion, let us consider a question focused on dietary education for a client with Parkinson's disease who is experiencing frequent constipation. The nurse must prioritize a teaching point that takes into account both the underlying pathophysiology of Parkinson's and the side effects of medications commonly prescribed for this disorder. Here are the available options: fresh fruits, wheat pasta, low-fat cheese, and canned vegetables. The correct answer is option 1, fresh fruits. The reason fresh fruits are the most important recommendation is that they are rich in dietary fiber, which adds bulk to stool and stimulates peristalsis. Clients with Parkinson's disease often experience constipation due to autonomic nervous system dysfunction, reduced gastrointestinal motility, lower levels of physical activity, and the constipating effect of dopaminergic medications such as levodopa. The fiber in fruits helps retain water in the intestines, softens stool, and speeds up colonic transit time. In addition, many fruits such as apples, pears, and prunes contain sorbitol, a natural sugar alcohol that works as a mild osmotic laxative. When combined with good hydration and regular exercise, fresh fruits become one of the most effective non-pharmacological strategies for constipation management in Parkinson's disease. Now, looking at why wheat pasta is not the best option, we see that most commercially available pasta is made from refined wheat flour, which has very little dietary fiber. Unless specifically labeled as whole wheat, it does not provide the indigestible bulk necessary for bowel motility. Clients with Parkinson's will benefit more from whole grains, bran, and oats than from regular wheat pasta. Turning to low-fat cheese, although it is lower in fat, it still contains almost no fiber and is known to slow bowel movements due to its protein and casein content. Cheese is therefore more likely to worsen constipation than relieve it. Finally, canned vegetables may seem like a reasonable option, but the canning process breaks down fiber, reducing its effectiveness. Added sodium in canned products can also contribute to fluid imbalance. For this reason, fresh or lightly steamed vegetables are much better choices for promoting bowel regularity. From a broader clinical standpoint, Parkinson's disease not only affects motor function, but also impairs the autonomic nervous system, leading to slowed gastric emptying and reduced colonic motility. Constipation becomes a persistent problem that can impact quality of life and even medication absorption. Nurses should emphasize non-pharmacological measures first, such as increasing fluids, adding fiber from fruits, vegetables, and whole grains, and encouraging as much physical activity as tolerated. Stool softeners or laxatives should only be considered when lifestyle interventions are insufficient. And here is your Stan Coast Pearl. In Parkinson's disease, fresh is best. Fresh fruits and vegetables keep the gut moving, while cheese and refined foods slow it down. Let us dive into another important NCLEX-style scenario to strengthen your clinical reasoning skills. An older client with progressive memory loss and behavioral changes is admitted to the Alzheimer's unit of a long-term care facility. During family teaching, the nurse explains that Alzheimer's disease has distinct neuropathological features that differentiate it from other types of dementia. Which finding is most characteristic of Alzheimer's disease and helps establish the diagnosis? Here are the available options to consider. Option 1, destruction of brain cells from chronic hypoxia. Option 2, destruction of brain cells following a cerebrovascular accident. Option 3, presence of neurofibrillary tangles and beta-amyloid plaques in the brain. And Option 4, a superficial bacterial or viral infection affecting the meninges. The correct answer is Option 3, presence of neurofibrillary tangles and beta-amyloid plaques in the brain. This is the hallmark finding that truly distinguishes Alzheimer's disease from other dementias. These tangles are made of hyperphosphorylated tau protein inside neurons, while amyloid plaques are protein deposits that accumulate outside neurons. Together, they disrupt synaptic transmission, trigger inflammation, and lead to progressive neuronal death. The hippocampus, which is crucial for memory, is one of the earliest areas affected, which explains why short-term memory loss is typically the first symptom noticed. As the disease advances, widespread cortical atrophy leads to impaired language, judgment, and behavioral regulation. Importantly, the identification of plaques and tangles on postmortem brain tissue is what provides the definitive diagnosis. Looking at Option 1, destruction of brain cells from chronic hypoxia, this is incorrect because hypoxia causes diffuse neuronal injury seen in conditions like respiratory failure, cardiac arrest, or severe hypotension. While hypoxia can cause cognitive impairment, it is not the core pathology of Alzheimer's disease. Turning to Option 2, destruction of brain cells following a cerebrovascular accident. This represents vascular dementia. Strokes lead to focal areas of brain damage and a stepwise pattern of cognitive decline, whereas Alzheimer's is gradual and progressive. Imaging in vascular dementia often shows multiple infarcts, while Alzheimer's typically reveals cortical atrophy with no direct vascular insult. Next, Option 4, a superficial bacterial or viral infection affecting the meninges, is also incorrect. Infections like meningitis or encephalitis cause acute symptoms such as fever, stiff neck, and altered mental status. While they may cause long-term cognitive issues if severe, they do not create amyloid plaques or tau tangles, and therefore are not diagnostic of Alzheimer's disease. To put this into clinical context, Alzheimer's disease accounts for 60 to 80% of dementia cases worldwide. Risk factors include increasing age, family history, and genetic markers such as the APOE4 gene. Unlike Lewy body dementia, which often presents with hallucinations and Parkinsonian features, or frontotemporal dementia, which primarily affects behavior and speech early on, Alzheimer's is uniquely tied to amyloid plaques and neurofibrillary tangles. Nursing care emphasizes structured routines, memory aids, maintaining safety, and supporting family caregivers through education and resources. Here is a Stand-Coast pearl to lock this in your memory. Think plaques and tangles when you think Alzheimer's. They are the neuropathological fingerprints that separate it from all other dementias. Let us now walk into another critical NCLEX-style scenario that focuses on dementia care and client safety. A client with moderate Alzheimer's disease is repeatedly observed wandering in and out of the unit despite frequent redirection. The nurse updates the care plan with a priority focus on maintaining safety. The question asks, which nursing intervention is most appropriate to include at this time? Here are the options for consideration. First, keep the client confined to the room. Second, attach an identity tag to the client's clothing. Third, lock all of the outside doors in the facility. Fourth, repeatedly remind the client of the facility's location. The correct answer is option 2. Attach an identity tag to the client's clothing. This is the best intervention because clients with Alzheimer's disease commonly suffer from memory loss, confusion, and poor judgment that put them at high risk for wandering and getting lost. Attaching an identity tag or registering the client in programs such as the Alzheimer's Association, Safe Return, or Medic Alert ensures that if the client leaves the unit, staff or community members can quickly identify and safely return them. This method balances autonomy and dignity with safety, aligning with evidence-based geriatric nursing practice and the NCLEX principle of choosing the least restrictive yet effective option. Now let us review why the other choices are incorrect. Keeping the client confined to the room may sound protective, but it actually increases agitation, anxiety, and depression. According to NCLEX frameworks such as least restrictive alternative, this is inappropriate unless the client poses immediate harm. Next, locking all of the outside doors in the facility might prevent elopement but creates a major fire and safety hazard. The Joint Commission and Fire Code standards highlight that exits must remain accessible. Instead, facilities should use alarmed or delayed egress doors. Finally, repeatedly reminding the client of the facility's location may seem supportive, but due to short-term memory impairment in Alzheimer's disease, clients cannot retain new information consistently. This strategy is ineffective and can increase frustration. To highlight the clinical takeaways, safety must always come first, but interventions should not strip away dignity or rights. NCLEX test. Writers often reward the answer that is both effective and least restrictive. Evidence supports the use of identification systems, alarm doors, and structured supervision to reduce wandering without harming quality of life. Complementary approaches include gentle redirection, safe walking areas, and meaningful activities to reduce agitation. Stand-Coast pearl. Wandering is a common and expected behavior in Alzheimer's care. It cannot always be eliminated, but it can be managed safely. The best nursing answer protects the client while still honoring freedom of movement. Let us now move into another NCLEX-style scenario that highlights both psychosocial care and client safety. A nurse is caring for a client diagnosed with moderate dementia, who insists on carrying a purse at all times, whether walking through the unit or receiving daily care. The question asks, which nursing intervention is most appropriate to support both the client's emotional needs and overall safety? Here are the possible options. First, ask the client where the purse can be stored. Second, ensure that the client is never without the purse. Third, inform the client that the purse may become lost. Fourth, find out why the client feels the need for a purse. The correct answer is option 2. Ensure that the client is never without the purse. Now, let us carefully analyze why this is the best approach. Clients with dementia often experience memory loss, disorientation, and anxiety, which make them cling to familiar objects such as a purse, wallet, or bag. These items often symbolize independence, security, and personal identity. Taking them away or challenging their use can increase distress, agitation, and even aggressive behavior. By respecting the client's attachment and allowing them to retain the purse, the nurse preserves dignity, maintains trust, and prevents behavioral escalation. If safety is a concern because of unsafe objects inside, the nurse can discreetly replace them with harmless alternatives, ensuring protection while preserving comfort. Looking at the other options, asking the client where the purse can be stored, which is option 1, is not appropriate because it demands abstract thinking and decision-making that clients with moderate dementia cannot consistently perform. Instead of reassurance, it can increase frustration and confusion. Informing the client that the purse may become lost, which is option 3, is also ineffective because rational explanations do not reduce anxiety in dementia. Logical warnings only create mistrust, paranoia, and heightened fear. Lastly, trying to find out why the client feels the need for a purse, which is option 4, may sound reasonable in theory, but is impractical here because dementia impairs the ability to explain motives or articulate complex reasons. Asking for justifications can lead to further resistance and agitation. In clinical application, this approach is supported by validation therapy, which focuses on accepting the client's perception of reality instead of correcting or challenging it. This method minimizes stress, supports cooperation, and addresses behavioral and psychological symptoms of dementia in the least restrictive and most compassionate way. Stan Coast Pearl. Always remember, in dementia care, dignity and emotional security take priority over strict logic or correction. A familiar object like a purse can act as an anchor of identity, and honoring that attachment can prevent distress more effectively than redirection or reasoning. Before continuing the NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX Prep, interactive live classes and easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lectures. This isn't just another review. It's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us continue with another thought-provoking NCLEX-style question that highlights both empathy and ethical care. A client with moderate dementia repeatedly asks, "Where is my mother?" Now, here are the possible nursing responses to consider. Option 1. Explain to the client, "Your mother died several years ago." Option 2. Tell the client, "Your mother will visit later." Option 3. State, "You miss your mother." What was she like? And option 4. Ask the client, "When did you last see your mother?" The correct answer is option 3. You miss your mother. What was she like? This choice best supports emotional well-being while preventing frustration and agitation. Clients with dementia often lose short-term memory, but retain long-term emotional connections. Parents symbolize comfort, safety, and identity, which is why questions about them frequently arise. By reflecting the client's feelings and encouraging reminiscing, the nurse validates their emotions and redirects them into safe, long-term memory recall, preserving dignity and reducing anxiety. Now let us examine the other options in detail. Option 1, telling the client your mother died several years ago, is incorrect because although factually true, it confronts the client's impaired cognition with a harsh reality they cannot integrate. This often triggers grief and distress each time it is repeated. Evidence shows that reality orientation may help in early dementia, but is harmful in moderate to late stages, where validation therapy is more appropriate. Moving on, option 2, telling the client your mother will visit later, is also incorrect because it constitutes false reassurance. While it may soothe the client momentarily, it violates the nursing ethical principle of veracity. If the client recalls later that the mother did not appear, mistrust and agitation can worsen. Effective dementia care avoids lies and instead focuses on validation and redirection. Next, option 4, asking, "When did you last see your mother?" is equally inappropriate. This type of questioning requires intact short-term memory, abstract thinking, and sequencing, skills that are impaired in dementia. Rather than comforting the client, it risks creating frustration, fear, or even aggression when they are unable to answer. The key clinical insight here is that in dementia care, the truth is not always therapeutic. The priority is emotional security. Validation therapy, acknowledging feelings and redirecting to safe, intact long-term memories, is the most effective strategy to reduce agitation, preserve dignity, and foster cooperation. That is why the correct response is to gently say, "You miss your mother." What was she like? Gliding into the next clinical moment, imagine a 48-year-old client with relapsing remitting multiple sclerosis, admitted with new onset double vision, fatigue, and impaired coordination after 6 months of remission, who confides, "I am terrified that I will lose my independence and become a burden." The nurse must choose the most therapeutic intervention for the client's immediate emotional needs. Here are the options woven into the scenario for smooth narration. First, encourage the client to verbalize feelings. Next, provide a detailed explanation of the disease progression. Then, tell the client about the current physical assessment findings. And finally, explain that the disease often alternates between periods of relapse and remission. The correct option is option 1, and the correct answer is encourage the client to verbalize feelings. Because in the heat of acute fear, the priority is to create a safe space where the client can name emotions, reduce internalized distress, and feel heard. This validates the person, builds trust, and lets the nurse assess coping strengths and unhelpful thoughts before moving to education. Consistent with Maslow's principle that emotional security precedes complex problem solving. Conversely, a detailed explanation of disease progression at this fragile moment may overwhelm the client and amplify anxiety. Education is essential, but is best offered after stabilization of feelings and readiness to learn. Likewise, reciting physical assessment findings centers the body while neglecting the mind, which risks minimizing the expressed fear and missing the true need. Similarly, offering factual reassurance about relapses and remissions may sound comforting, but bypasses the emotion itself, which can feel invalidating and erode trust. Clinically, multiple sclerosis is a chronic immune-mediated demyelinating disorder of the central nervous system with unpredictable exacerbations. During exacerbations, fear and loss of control often eclipse physical symptoms. So therapeutic communication comes first, and structured teaching, coping strategies, and self-management planning follow once the client feels anchored. Stand coast. Pearl. Feelings first, facts later. Validate and listen before you teach. Because emotional safety is the doorway to effective learning and long-term coping. Let us now shift our focus to another high-yield NCLEX practice scenario. A 42-year-old client who has been recently diagnosed with multiple sclerosis is admitted for rehabilitation after reporting progressive fatigue, muscle weakness, and increasing difficulty in completing activities of daily living. The nurse is developing a care plan to promote independence while ensuring the client does not become overexerted. The question asks, which nursing intervention is most appropriate when assisting this client with activities of daily living? Here are the options to consider. The first option is to limit the time for performing activities of daily living to 30 minutes. The second option is to eliminate all tasks that the client is unable to perform. The third option is to encourage the client to rest between activities. The fourth option is to perform all of the client's activities of daily living to conserve energy. The correct answer is option 3, which is to encourage the client to rest between activities. This choice is correct because multiple sclerosis is a chronic demyelinating disorder of the central nervous system, characterized by relapses, remissions, and a hallmark symptom of profound fatigue. Unlike normal tiredness, MS-related fatigue is unpredictable, worsens with exertion, and is not relieved by simple rest. Encouraging breaks between activities provides the client with structured energy conservation, prevents symptom exacerbation, and promotes sustainable independence. Evidence-based practice strongly supports pacing, task prioritization, and scheduled rest periods as the cornerstone of long-term self-care. From Maslow's perspective, maintaining energy balance and physiologic stability must come before striving for higher-level needs like autonomy and self-esteem. Looking at the incorrect options, option 1, which suggests limiting the time for ADLs to 30 minutes, is not therapeutic. While time management matters, imposing a strict and arbitrary limit ignores the client's fluctuating tolerance and may lead to frustration and stress when goals are not met. Option 2, which is to eliminate all tasks the client cannot perform, strips away opportunities for independence. Many clients can perform at least partial components of tasks, and denying this participation fosters helplessness rather than rehabilitation. Option 4, which is to perform all of the client's ADLs, may conserve energy in the short term, but undermines self-esteem and accelerates dependency. Rehabilitation emphasizes enabling clients to perform to their highest functional ability, not replacing their efforts entirely. Here are some key clinical pearls to remember. Fatigue management in multiple sclerosis is not about eliminating activity, but about doing activities smarter through pacing, adaptive devices, and rest breaks. Nursing care should always balance rest with activity rather than removing activity altogether. Rigid time limits are far less effective than flexible, client-centered pacing. Preserving independence, even in small ways, supports dignity and reduces psychological decline. Stan Coast, Pearl. In multiple sclerosis, the best way to support clients is to teach them how to work with their energy, not against it. Encourage pacing, planned rest, and adaptive strategies to preserve both independence and dignity. Shifting our attention now to an important discharge teaching scenario. Imagine a 35-year-old client with relapsing remitting multiple sclerosis who is preparing to leave the hospital. The nurse must educate the client on lifestyle modifications to prevent worsening of fatigue and neurologic symptoms. The key question becomes, which environmental factor should the nurse emphasize as most critical for this client to avoid? The options presented are hot weather, wet climates, dry environments, and cold temperatures. The correct answer is option 1, hot weather. Here is the reasoning behind this decision. Multiple sclerosis is a chronic autoimmune demyelinating disorder of the central nervous system. As myelin is lost, nerve conduction is disrupted, producing fatigue, weakness, spasticity, impaired coordination, and sensory changes. One hallmark of the disease is profound fatigue, which can be exacerbated by stress, infection, or environmental triggers. Among these, heat exposure is the most critical risk factor. Even a slight rise in core body temperature, whether from hot weather, fever, hot baths, or saunas, can worsen nerve conduction in demyelinated fibers, producing blurred vision, greater weakness, severe fatigue, and spasticity. This effect is known as Uthoff's sign, and it explains why avoiding heat becomes the nurse's highest teaching priority. When analyzing the other choices, wet climates may cause discomfort, but humidity alone does not impair conduction or trigger relapses. Similarly, dry environments might contribute to skin or mucous membrane irritation, yet they have no significant neurologic impact in multiple sclerosis. Cold temperatures may cause stiffness or spasticity, but many clients actually tolerate cooler settings better. And cold does not directly block conduction the way heat does. From a clinical judgment perspective, the nurse's responsibility is to address the most immediate physiologic threat. Applying Maslow's hierarchy, maintaining neurologic stability by preventing heat-induced conduction block outweighs issues of comfort. Evidence consistently supports this. Research shows that 60 to 80% of clients with multiple sclerosis report worsening fatigue and neurologic symptoms with elevated temperatures. Nurses should therefore teach practical cooling strategies, such as staying in air-conditioned spaces, scheduling activities during cooler times, avoiding hot showers or baths, drinking plenty of fluids, and using cooling vests if necessary. Stan Coast, Pearl. Always remember the phrase, heat hurts in MS. Even a small rise in temperature can short-circuit demyelinated nerves. Cooling measures are the client's best defense for conserving energy and controlling symptoms. Let us now move forward with another advanced NCLEX-style scenario that focuses on medication administration and client education. A client with relapsing remitting multiple sclerosis has been prescribed interferon beta 1A, commonly known as Avonex, for long-term disease management. The nurse is preparing to give the medication subcutaneously and must reinforce teaching about rotating injection sites. The question asks, when alternating injection sites on the client's upper arms, what is the minimum distance each injection should be spaced apart to prevent complications and ensure proper absorption? Here are the available options. The first choice is 1/4 of an inch, which is equal to 0.6 centimeters. The second choice is 1/2 of an inch, which is equal to 1.3 centimeters. The third choice is 1 inch, which is equal to 2.5 centimeters. The fourth choice is 2 inches, which is equal to 5 centimeters. The correct answer is option 3, 1 inch, or 2.5 centimeters. This is because subcutaneous injections must be spaced at least 1 inch apart in all directions to protect the tissue and ensure consistent absorption. To understand the rationale more clearly, let us first look at the medication itself. Interferon beta 1A is a disease-modifying therapy for multiple sclerosis that slows disease progression and reduces the frequency of relapses. Since it is given subcutaneously over a long-term period, proper site rotation is critical to avoid problems such as redness, swelling, nodules, or even tissue necrosis. Next, let us examine why this spacing is so important. When subcutaneous injections are placed less than 1 inch apart, the medication deposits overlap in the same tissue pocket. This increases the risk of irritation, inflammation, fibrosis, or impaired absorption. Educators often use the analogy of a small dot adhesive bandage to demonstrate how much space is needed between each injection site. Now, let us break down why each option is correct or incorrect. Beginning with option 1, 1/4 of an inch is far too close together. It would essentially deliver medication into the exact same area, causing accumulation and irritation. Option 2, 1/2 of an inch, is slightly better, but still insufficient to allow adequate tissue healing, and it still risks overlapping medication sites. Option 3, 1 inch, is correct because it provides the proper balance of spacing to preserve skin integrity and optimize absorption. Option 4, 2 inches, is technically safe but unnecessary. Such wide spacing would severely limit available injection sites over time and make long-term therapy impractical. There are also additional teaching points for clients. They should never inject into areas that are bruised, scarred, hardened, inflamed, or tender. Rotation should include not only the arms, but also the thighs, abdomen, and buttocks. Many clients find it helpful to keep a log or use injection site mapping tools to avoid overlap. And finally, they must report any severe or persistent injection site reactions to their healthcare provider, since adjustments in therapy might be required. Stand coast. Pearl. Always remember the 1 inch rule for subcutaneous injections. Keeping injections at least 1 inch apart protects the tissue, maintains consistent drug absorption, and prevents long-term complications. Using the size of a small bandage dot as a quick guide is a simple and effective teaching strategy for both nurses and clients. Moving into our next scenario, let us focus on discharge teaching for a client with relapsing remitting multiple sclerosis who has just started interferon beta-1A therapy. The client is preparing for self-administration of subcutaneous injections and asks which sites should be rotated to reduce complications and improve absorption. The nurse must emphasize the safest, most evidence-based practice. Here are the options to consider. First, rotate injections between the thighs and hips. Second, rotate injections between the forearms and hips. Third, rotate injections between the thighs and abdomen. And fourth, rotate injections between the abdomen and buttocks. The correct answer is option 3, rotate injections between the thighs and abdomen. This is the safest and most practical choice for clients learning self-administration. Let us now explore the reasoning step by step. Interferon beta-1A is a disease-modifying therapy designed to decrease relapse frequency and slow the progression of multiple sclerosis. Because it is given subcutaneously, rotating injection sites is critical to protect tissue, prevent irritation or lipodystrophy, and ensure reliable absorption. The abdomen is particularly important because it offers the most consistent and fastest absorption due to steady blood flow, while the thighs provide slower but dependable absorption, balancing the drug's pharmacokinetics. Both sites are easy for clients to reach independently, which is essential for those who may have mobility limitations. Now, considering why the other sites are less appropriate, option 1, thighs and hips, is problematic because although the hips may technically work, they are difficult to reach independently, which increases the likelihood of improper technique and dependence on caregivers. Shifting to option 2, forearms and hips, we find that forearms are not recommended for subcutaneous administration because they contain limited subcutaneous tissue, making injections more painful and risking bruising or accidental intramuscular delivery. Finally, option 4, abdomen and buttocks, is not ideal because injections in the buttocks have inconsistent absorption patterns and are often impractical for self-administration, especially for clients with neurologic or mobility challenges. An additional rule for safe injection technique is that all subcutaneous injections should be spaced at least 1 inch or 2.5 centimeters apart from one another. This spacing prevents overlapping trauma, reduces nodules, and preserves proper absorption. Teaching must also include cleansing the site with alcohol and allowing it to dry, using the correct angle of 45 to 90 degrees based on tissue thickness, and avoiding bruised, scarred, or infected areas. Clients should keep a simple record of rotation to avoid repeating sites too soon. Stand coast Pearl. For interferon beta, 1A and other subcutaneous therapies, the abdomen and thighs remain the gold standard. They offer accessibility, consistent absorption, and independence for clients. Always rotate carefully within and between these regions, keeping at least 1 inch of spacing to protect the skin and preserve the therapeutic effect of the drug. Shifting into our next scenario, imagine a client with relapsing remitting multiple sclerosis who has recently started interferon beta 1A, also known as Avonex. During a follow-up visit, this client reports persistent anorexia and nausea linked to the therapy. The nurse must decide on the most appropriate action to both support adherence and maintain nutritional status. The available choices are as follows. First, withhold the medication. Second, offer frequent mouth care. Third, administer the drug after meals. And fourth, provide small, easy-to-digest meals. The correct response is option 4, provide small, easy-to-digest meals, because this intervention addresses the side effect while keeping the client on their essential disease-modifying therapy. To break this down step by step, interferon beta 1A is not just a symptom reliever. It is a disease-modifying therapy that decreases relapse rates, reduces lesion development on MRI, and slows physical disability. That means adherence is absolutely vital. Stopping the drug for mild gastrointestinal upset, as suggested in option 1, would undermine its long-term therapeutic benefit. Offering frequent mouth care, as in option 2, might refresh taste but does little to ease the actual nausea or anorexia. Option 3 also falls short because interferon beta 1A is administered intramuscularly once weekly, making meal timing irrelevant since it bypasses the gastrointestinal tract entirely. On the other hand, option 4 is correct, because small, frequent, easy-to-digest meals can significantly reduce nausea triggers, prevent overwhelming the stomach, and help maintain adequate nutrition, all of which directly support the client's tolerance and adherence to therapy. Here is the clinical pearl. Nurses caring for clients on interferon therapy must learn to manage the side effects without interrupting treatment. Flu-like symptoms, anorexia, and nausea are common but usually manageable through supportive interventions, such as light meals, hydration, and antiemetics if ordered. Discontinuation should only occur for serious reactions, such as hepatotoxicity, bone marrow suppression, or severe depression. And the stand-coast pearl to remember is this. For interferon therapy, manage the side effects, not the medication. Keeping nutrition adequate through small, frequent, easy-to-digest meals is the best strategy to improve tolerance and prevent unnecessary treatment interruption in a therapy that is essential for slowing the progression of multiple sclerosis. As we move forward, let us consider an important question on multiple sclerosis and skincare. A nurse is performing a physical assessment of a client diagnosed with multiple sclerosis who reports intermittent weakness and numbness in the lower extremities. During the examination, the nurse notes decreased sensation, poor proprioception, and limited ability to reposition independently. The key concern here is which nursing intervention is the most appropriate to include in the care plan to prevent impaired skin integrity at this stage? Here are the options to think about. First, utilize an air fluidized, also known as clinitron, specialty bed to redistribute pressure. Second, reposition the client at least every 2 hours and assess bony prominences. Third, massage reddened areas of skin to promote circulation. And fourth, schedule daily hyperbaric oxygen therapy sessions to improve tissue oxygenation. The correct answer is option 2. Reposition the client at least every 2 hours and assess bony prominences. Let us break down why this is correct and why the other options are not. Starting with the correct option, repositioning every 2 hours is the gold standard preventive strategy supported by evidence-based practice. Clients with multiple sclerosis often cannot sense pressure buildup or move themselves easily. So consistent repositioning relieves pressure, improves circulation, and allows nurses to detect early skin changes before ulcers develop. It also promotes independence when the client is taught to shift weight if partial mobility is retained. Turning to option 1, the use of an air fluidized bed may sound helpful, but it is reserved for clients who are completely immobile or already suffering from stage 3 or 4 pressure injuries. These beds are costly and unnecessary when intact skin can be protected through standard preventive repositioning. Looking at option 3, massaging reddened areas is actually harmful rather than helpful. This action increases shear and capillary damage, worsening ischemia instead of improving circulation. Current skincare guidelines emphasize gentle repositioning and protective devices, not friction-producing massages. Finally, option 4, hyperbaric oxygen therapy, plays no role in prevention. It is an advanced, costly intervention used for healing chronic non-healing wounds like diabetic ulcers or osteomyelitis. For a client with intact skin, this therapy is not only inappropriate but also impractical. To close with a clinical pearl, in neurological conditions such as multiple sclerosis, prevention is everything. Repositioning every 2 hours, patting bony prominences, keeping skin dry and clean, and maintaining good nutrition are the foundations of preserving skin integrity. Specialty beds or hyperbaric oxygen should be considered only after preventive strategies fail or when ulcers have already developed. To kick things off, imagine you are reviewing the history of an older adult newly diagnosed with myasthenia gravis, and you must decide which reported finding most strongly reflects a classic manifestation of this neuromuscular disorder. Now, consider the options one by one. Option 1 is sudden hearing loss. Option 2 is sensitivity to light. Option 3 is drooping eyelids. And option 4 is a protruding tongue. Moving from possibilities to priority, the correct answer is option 3, drooping eyelids, that is, ptosis. Because myasthenia gravis is a chronic autoimmune disorder in which autoantibodies target acetylcholine receptors at the neuromuscular junction, reducing neuromuscular transmission and producing fluctuating skeletal muscle weakness that worsens with repeated use and improves with rest. And importantly, the earliest and most common involvement is ocular. Ptosis and diplopia are frequent first signs, often exacerbated by sustained upward gaze and relieved by short rest. Shifting to the incorrect choices, option 1, sudden hearing loss, does not fit because myasthenia gravis affects skeletal muscles while the auditory sensory pathways remain intact. So, a sudden loss of hearing points instead toward conditions such as Meniere disease, acoustic neuroma, or vascular compromise. In contrast, option 2, sensitivity to light, is not characteristic because myasthenia gravis does not impair the optic nerve or pupillary constriction fibers. And although double vision occurs from extraocular muscle weakness, photophobia is more consistent with migraine, meningitis, or uveitis. Finally, option 4, a protruding tongue, is misleading because bulbar involvement in myasthenia gravis causes fatigable tongue and facial weakness that leads to dysarthria, nasal speech, choking, and difficulty swallowing rather than a persistently protruding tongue, which is more compatible with structural macroglossia, hypoglossal nerve palsy, or syndromic conditions. Pulling the essentials together for NCLEX readiness. Remember the high-yield sequence, eyes first, then swallowing, then breathing to prioritize risk. Ocular weakness commonly appears early, bulbar symptoms, dysphagia, and dysarthria. Signal aspiration risk, and progression to generalized or respiratory muscle weakness raises the danger of myasthenic crisis requiring airway support. For confirmation and management, modern diagnosis relies on acetylcholine receptor or muscle-specific kinase antibody testing and electrophysiologic studies, such as repetitive nerve stimulation and single-fiber electromyography, while treatment centers on acetylcholinesterase, inhibition with pyridostigmine, immunosuppression when needed, and thymectomy when a thymoma is present. In summary, keep your narration crisp at the bedside. Early ocular signs like ptosis and diplopia are the hallmark. Weakness is fatigable and improves with rest. The sensory system, including hearing, remains normal. Photophobia suggests another diagnosis, and bulbar symptoms warn you to think airway. Stand coast, pearl. Always scan for ptosis first, screen for aspiration second, and never miss subtle signs of impending respiratory compromise. Let us continue our NCLEX preparation journey with another high-priority clinical scenario. A nurse is caring for a client with a history of myasthenia gravis, who presents with acute worsening of symptoms suggestive of a myasthenic crisis. The key question is, which assessment finding should the nurse monitor most closely to ensure immediate client safety? Here are the possible answers. Breathing, temperature, blood pressure, or mental status. The correct answer is option 1, breathing. This is because myasthenia gravis is an autoimmune disorder where antibodies destroy acetylcholine receptors at the neuromuscular junction, leading to fluctuating skeletal muscle weakness. During a myasthenic crisis, weakness escalates to life-threatening levels, primarily affecting the diaphragm and intercostal muscles responsible for ventilation. Without vigilant monitoring of respiratory function, the client is at risk of hypoventilation, hypoxemia, and eventual respiratory arrest. Early recognition of shallow breathing, weak cough, or difficulty speaking allows for timely interventions such as airway support, suctioning, or mechanical ventilation. According to NCLEX prioritization rules, airway and breathing take precedence over all other physiological needs. Looking at the other options, temperature monitoring is certainly important because infections can trigger a myasthenic crisis. However, fever does not pose an immediate threat compared to compromised breathing. Blood pressure should also be observed, yet it is generally a secondary issue and is not the central danger in myasthenia gravis crisis. Finally, while altered mental status may occur due to hypoxia or carbon dioxide retention, it is a later finding. By ensuring adequate respiratory function first, nurses can prevent this complication from developing. Here is the Stand Coast Pearl. In a myasthenic crisis, watch the chest before the chart. That means nurses must focus on respiratory rate, depth, effort, ability to speak in complete sentences, and the strength of the cough before concentrating on vital signs or neurological assessment. Timely identification of respiratory distress is the single most life-saving nursing action in this condition. Let us now move into another essential NCLEX-style scenario that highlights the importance of prioritizing client safety. A nurse is planning care for a client newly diagnosed with myasthenia gravis who has developed progressive bulbar muscle weakness. During the initial assessment, the client demonstrates difficulty swallowing liquids and even has episodes of coughing while eating. This situation places the client at significant risk. So the question becomes, which equipment is most essential for the nurse to keep at the bedside to ensure immediate safety? Here are the possible options. Option A is a bite block in case of seizures. Option B is a cardiac defibrillator in case of cardiac arrest. Option C is a suction machine in case of compromised swallowing. Option D is a cooling blanket in case of hyperthermia. The correct answer is option C, a suction machine in case of compromised swallowing. To explain this step by step, myasthenia gravis is an autoimmune disorder in which antibodies attack acetylcholine receptors at the neuromuscular junction. This leads to skeletal muscle weakness that fluctuates in severity. When the bulbar muscles, which control swallowing, chewing, and speech, are affected, the client faces the greatest risk to airway safety. Dysphagia, impaired cough, and weak airway protection put the client at high risk for aspiration. According to the NCLEX ABCs framework, airway and breathing always come before any other need, which is why the nurse must anticipate airway compromise and prepare accordingly. Looking at why option C is correct, the suction machine is essential because the client's dysphagia can lead to aspiration of food, liquids, or secretions. Without the ability to cough effectively, the client may be unable to clear their airway, leading to obstruction, hypoxemia, or aspiration pneumonia. Having suction equipment readily available allows the nurse to intervene immediately and remove secretions or aspirated material, which can prevent life-threatening complications. This simple piece of equipment directly safeguards the client's airway and oxygenation. Considering why the other options are incorrect, option A, the bite block, is not relevant since seizures are not a typical manifestation of myasthenia gravis. The disorder causes muscle weakness, not abnormal electrical activity in the brain. Option B, the cardiac defibrillator, is critical in cardiac emergencies, but myasthenia gravis does not predispose clients to sudden arrhythmias or arrest. Defibrillators are kept on crash carts, not at every bedside. Option D, the cooling blanket, may be useful for hyperthermia, but fever is not a direct complication of myasthenia gravis. In fact, infection or elevated temperature can worsen symptoms, yet managing airway compromise always comes first. From an NCLEX perspective, this reinforces the clinical priority rule. Airway and breathing interventions take precedence over circulation, comfort, or infection control. Ensuring suction availability aligns directly with this principle, as it prevents respiratory decline in a high-risk client. Here is your Stand Coast Pearl. In clients with myasthenia gravis, always think airway first. Bulbar weakness is dangerous because it impairs swallowing and increases aspiration risk. That is why suction equipment at the bedside is not optional. It is absolutely essential for safety. Let us now consider a high-stakes scenario involving a client newly diagnosed with myasthenia gravis who has been prescribed pyridostigmine bromide, also known as Mestinon. The provider has explained that the dosage will be carefully titrated based on how the client responds, but as the nurse, you must know which action is most essential for controlling the neuromuscular symptoms that define this condition. Here are the options to think about. The first option is ensuring that the client has regular bowel and bladder elimination. The second option is administering each dose of medication at the precise scheduled time. The third option is encouraging the client to exercise twice daily for 30 minutes. The fourth option is providing nutritional supplements between each meal and at bedtime. The correct answer is option 2. Administer each dose of medication at the precise scheduled time. This is the priority, because myasthenia gravis is a chronic autoimmune neuromuscular disorder, where antibodies attack acetylcholine receptors at the neuromuscular junction. The result is fluctuating skeletal muscle weakness that worsens with activity and improves with rest. The most dangerous complications involve weakness of bulbar muscles that control swallowing and speech, as well as respiratory muscles that maintain breathing. Pyridostigmine helps by prolonging acetylcholine action at the neuromuscular junction, which improves muscle contraction. However, the drug has a short half-life of only 3 to 6 hours, so even small delays in administration can cause end-of-dose weakness, while excess dosing can lead to a cholinergic crisis. For this reason, precision in timing is the nurse's most essential role. Looking at the incorrect choices, ensuring regular bowel and bladder elimination is supportive but does not prevent neuromuscular weakness. Encouraging daily exercise may actually precipitate fatigue and worsen symptoms if not carefully balanced with rest. Providing nutritional supplements can help maintain weight and strength, especially when chewing and swallowing are impaired, but it does not directly impact the neuromuscular transmission itself. And here is your Stancoast Pearl. Think of pyridostigmine as a time-sensitive key that unlocks muscle strength only for a limited duration. If the medication is delayed, the door to muscle control shuts, leaving the client weak, vulnerable to aspiration, and even at risk of respiratory failure. This is why timely medication administration should always be the nurse's top priority. All right, future nurses, let us carefully walk through this question together. We are focusing on bladder training for a client with a neurogenic bladder, who has been instructed to use the Creed's maneuver to promote complete bladder emptying. The key here is identifying which client action shows that the technique is being done correctly. Here are the options to consider. The first option is contracting and relaxing the urinary sphincter 10 to 25 times daily. The second option is squeezing the urinary sphincter, holding for 3 seconds, and then repeating. The third option is bearing down forcefully while taking a deep breath and slowly releasing it. The fourth option is applying gentle, steady downward hand pressure over the bladder from the umbilicus toward the symphysis pubis. The correct answer is option 4, applying gentle, steady downward hand pressure over the bladder from the umbilicus toward the symphysis pubis. This is the true Creed's maneuver. Now, let us break down why. The Creed's maneuver is a manual bladder emptying technique most commonly used in clients with neurogenic bladder, spinal cord injury, or impaired detrusor function. In these situations, nerve signals or muscle contractions are not strong enough to empty the bladder completely. By placing the hands just above the pubic area and applying steady downward pressure, urine is mechanically expressed, helping prevent retention, urinary stasis, reflux, infection, or renal complications. This maneuver is non-invasive, avoids repeated catheterization, and is safe when performed gently at regular intervals. Looking at the other options, the first option, contracting and relaxing the sphincter repeatedly, describes Kegel exercises. These are excellent for pelvic floor strengthening after childbirth or for stress incontinence, but they do not empty the bladder. The second option, squeezing and holding the sphincter, is also another form of pelvic floor training, not related to Creed's maneuver. The third option, bearing down forcefully while holding a deep breath, is actually the Valsalva maneuver. While it might increase abdominal pressure to start urination, it can cause complications such as bradycardia, syncope, or high bladder pressures that could push urine back into the ureters, making it unsafe for long-term use. So the clinical priority is clear. Creed's maneuver is the safe, effective manual method to promote bladder emptying in clients with impaired bladder contractility. Stancoast, Pearl. Remember this simple memory trick? Creed means press down. Kegel strengthen, Valsalva bears down, but Creed is gentle hand pressure over the bladder to help it empty completely. Let us now transition into another important advanced NCLEX scenario that highlights both clinical reasoning and nursing judgment. A 60-year-old client with late-stage amyotrophic lateral sclerosis, also known as ALS, is admitted to the hospital. The client presents with progressive muscle weakness, increasing difficulty swallowing, and requires support for ambulation and feeding. The key question is, based on the usual trajectory of this disease, which nursing diagnosis should be prioritized in the care plan? Here are the options to consider. Option 1 is sexual dysfunction. Option 2 is disturbed body image. Option 3 is impaired memory. Option 4 is self-care deficit. The correct answer is option 4, self-care deficit. To understand the reasoning, let us first explore the disease process. ALS is a progressive, fatal neurodegenerative disorder that involves the degeneration of both upper and lower motor neurons in the motor cortex, spinal cord, and brainstem. The hallmark manifestation is relentless skeletal muscle weakness and wasting, while sensation, cognition, and autonomic function usually remain intact. Onset is most common between the ages of 40 and 70, with a slight male predominance. Unfortunately, life expectancy is generally 3 to 5 years after the initial symptom onset, with respiratory failure and pneumonia being the leading causes of death due to involvement of respiratory muscles. Now focusing on why self-care deficit is correct. As ALS advances, clients lose voluntary motor control and progressively become unable to carry out activities of daily living, such as walking, dressing, bathing, toileting, and eating. In late-stage ALS, dependence on caregivers for all aspects of daily care becomes absolute. Nursing interventions therefore prioritize maintaining independence for as long as possible with adaptive equipment, and then ensuring adequate caregiver and multidisciplinary support when independence is lost. Planning ahead for nutrition, mobility, hygiene, and elimination is essential to preserve both safety and dignity. Turning to the incorrect options, let us start with sexual dysfunction. Although physical limitations, fatigue, or psychological strain may influence sexual health, ALS itself does not impair sexual function because sensation and cognition are spared. Therefore, while it may be a relevant secondary diagnosis for some, it is not the central or universally prioritized issue in late-stage ALS. Next is disturbed body image. This may occur as a result of visible muscle wasting, loss of independence, or the use of medical devices such as wheelchairs, feeding tubes, or tracheostomies. However, it is not as inevitable or as critical to survival and daily functioning as the self-care deficit. Lastly, impaired memory is not correct, because cognitive function is usually preserved in ALS. Although a minority of clients may develop frontotemporal dementia, this is not the defining or most expected feature of the disease. ALS is distinct from dementias in that the mind generally remains intact even as physical capabilities decline. Here is the Stan Coast Pearl to anchor your learning. In ALS, the mind is intact, but the muscles fail. This means nursing care must focus on anticipating the progressive decline in self-care ability, while continuing to respect and support the client's preserved cognition, decision-making, and emotional needs. Prioritizing self-care deficit ensures nurses plan ahead for caregiver support, assistive devices, and interdisciplinary care, all aimed at maintaining quality of life and dignity throughout the disease's course.